On this episode of the Ask Mike Reinold Show, we talk about 2 post-operative techniques. We talk about how a posterior lateral corner reconstruction could impact your ACL progression, and we talk about a superior capsular repair for an irreparable, massive rotator cuff repair. That was a big one. The Ask Mike Reinold Show. Helping people feel better, move better, and perform better. Welcome back, everybody, to the latest episode of the Ask Mike Reinold Show. We're up at Champion PT and Performance up in Boston, Mass. Lenny Macrina, Dan Pope, Dave Tilley, Mike Scaduto. A little difference there, right? We're getting there. We have our awesome students here to ask us some awesome questions from our awesome listeners. I feel like I'm at an Apple event right now. We have an amazing podcast.
This is the best version of the Mike podcast ever.
This is an amazing episode here. It's going to be so much better. So we have Adam Pizzow.
Ow! This is hell.
I like it. Maybe, that's what we should do for him.
Pizzow, 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 pizzow.
No, then it's like it goes down the line. Everybody does a different one. And then
Kapow,
boom,
bang.
Wait. All right, ready? Everybody get their phrase?
Yep.
Everybody get their exclamation? Ready? Adam Pizzow.
Kaping!
This is a classic episode, right? Thanks, Adam. That's good stuff. He is from NYT, the New York Institute of Technology.
Monty Python, man.
NYT. He's
also
from
Russian for no.
That's good. That's actually a good point. That's in there. But yeah, physical therapy, the tech side of physical therapy. And we have Andrew Kirschbaum from Oakland University.
As you guys can see, it's November-ish in this podcast filming, so yes.
Yeah.
A mustachial question.
Terrible decision on K-Bomb. I don't know if anyone can zoom in on his face right now, but yeah, good one.
That looks good.
And then obviously fan favorite, everybody's favorite, Brian Winkler here for another awesome episode. So who wants to take it away?
I'll go ahead.
Pizzow!
Hi,
You're
Mike
ready.
Crew. I just got my first post-op ACL and posterior lateral corner reconstruction case. From the research I've done, it seems that PLC dictates the rate at which we progress through exercises. Any helpful advice or resources would be appreciated.
All right, so this is an interesting one. ACL post-op with a posterior lateral corner, which is certainly more complicated.
Give it to the student.
Before let the student figure that one out. Before Lenny, we can let you answer this one obviously, but before we get into that, like, have you ever seen an ACL with a posterior lateral corner in isolation?
No, I mean,
Like,
it's usually like other stuff
blowout.
going on.
No
Yeah.
PCL or LCL?
Yeah, usually.
It's kind of hard, right?
Right.
It's usually like all gone.
I don't want to say like never, but
Yeah,
like
maybe you didn't give us the whole.
That's like a 300-pound
the whole
lineman
picture.
fell on your leg and
Yeah,
just
like-
tore through it all.
to get an anterior tibial translation and a posterior lateral, that has to be like a huge hyperextension, but a hyperextension lateral
Yeah.
kind of movement there. It'd be really hard to not dislocate like ACL, PCL, and do LCL. So, that's my first thing that jumped out is this is complicated, and this may be more complicated than even that. Right? But, I don't know. I mean, am I off on that just before you even answer?
No, I mean, hearing the question too, I would assume there's more to it, but maybe not. So I can't assume, I guess. But
Yeah.
usually there's a PCL component. Usually there's a meniscus component too, just because of the rotation and the sharing that had gone on. So I think just taking a step back and thinking about the anatomy that's involved, because you got to protect those structures, right? So you got LCL, which I would assume was involved. At some aspect, maybe if it's just a grade 2 sprain, but still it's involved. You have popliteus that's probably involved. You have probably maybe some form of the biceps, lateral biceps that might be involved. So I've seen that. So you got to respect that. Yeah, not that biceps. You got to respect that soft tissue healing. So how I would treat it would be you got to go by obviously by your doc, but you got to respect that hyperextension. So I wouldn't push hyperextension because of the popliteus component and that kind of the screw home mechanism that's involved with it. I'd also be cautious of lateral leg raises like abduction because of the LCL and the lateral structures, so you got to be cautious with that. And you also got to watch, it's probably limited weight bearing too, I would imagine. If not, you may want to just be cautious of that because of the weight bearing with a rotational component to it could do something to the healing structures. And I'd probably hold that for a few weeks easily. Some docs would wait 6 weeks for weight bearing, I've seen as well, but
Completely, even with like a brace lock and extension?
Yes, but I don't agree with it. So brace should be locked in extension. You should be able to do quad sets. I'd still be cautious. I used to put something under somebody's knee to prevent that hyperextension early on. I don't want to lose hyperextension, but I also don't want to get into deep hyperextension. So I'd be cautious with that. Patella mobs, and that first 6 weeks just kind of go easy. Range of motion should be to relative tolerance, although getting into deeper amounts of flexion may stress some of those posterior lateral structures. So I'd be a little cautious with that, but you should be able to get 90 degrees for the first 2 weeks.
Could you do above the knee joint? That's the question. Could you do above the knee joint like resistance bands and like manual stuff if you want to maintain abduction? You know, same with that we go like above the road for a humeral cuff thing.
I got you.
I don't know if that'd be possible.
Probably.
Yeah, you
I
probably
guess you can get creative
I'd
that way.
I'd still delay that,
Yeah.
even just like the gravity
Right.
of it or the position
Yeah,
of
you
it.
could do isometrics.
And don't forget too, I think it's a rotary torque that has
Right.
something to do with
Right.
it too. It's not just like it's not exactly.
Yeah.
It's not just straight lateral.
So I mean, yeah,
Everything's delayed a little bit.
everything
you know?
is delayed.
It's a bigger deal.
Yeah, you don't want them to get, and especially if it's a younger female. I don't know what the demographics are, but females are going to get looser in those structures than guys. Just in general, I feel like. So you got to be cautious with that. So just ligaments in general, just tend to loosen up laterally. Probably not as much swelling and stiffness as if it was a medial side issue. So your range of motion oftentimes comes back relatively easy, but I agree the ACL component is not going to be as limiting as the posterior lateral corner component.
You're gonna slow it down a little bit. It's
Yeah.
probably gonna be slowed down, give or take, like at least 2 weeks. I'd say an
Right.
advanced level athlete.
Yeah.
I wouldn't be surprised just being a couple weeks.
Right.
I can see in the general pop 4 week kind of like slow down with some of those precautions in there.
Right.
I think it would be pretty solid. So. Yeah, have fun with that one.
Yeah,
it's a good one.
That's a fun one.
So it's good to see different ones like
put it
that.
in the memory bank. Do some
Yeah.
research on it, and then you are the person for
So random
for that.
But Terry Malone's course on MedBridge is extremely helpful for that. I took that.
Oh, really?
I had a
It's random.
I had a really complex knee, and he goes through like all the different structures testing, posterior
Nice.
lateral, anterior
Yeah.
rotary.
Yeah.
I was like, I had never even knew this existed, so it was really helpful.
Yeah, no, Terry's awesome. And so I would just say I would also reach out to the doc if I were you.
Yeah,
and
just over communicate.
there could be a big PCL,
Yeah.
sprain, and you remember too that PCLs don't always do well if you reconstruct them. So oftentimes they don't. So if they have some posterior laxity, that's also going to probably change.
Right. Yeah. Get the op report so you have all the
Yeah.
information. Look at the meniscus. Look at joint structure, like articular cartilage structures. How was that? Because it sounds like it was a pretty
Right.
good injury. So there's probably some bruising going on, bone bruising going on the joint, and anything else. So I would get
Yeah.
as much information as possible.
Articular cartilage.
Articular
kid.
cartilage.
Yeah.
Whatever.
Yeah.
Great, Boston.
Lenny. Awesome. Good question. What's next?
Alright, Dom in Cincinnati. Hey Mike, a few orthosurgeons our practice works with closely are starting to perform superior glenohumeral capsular reconstructions as an alternative to massive rotator cuff repairs. Some protocols indicate rehab similar to a standard rotator cuff repair with immediate passive motion as tolerated, while others are decelerated and limit cuff strengthening until 4 to 5 months. What are your initial thoughts on how they should be progressed with rehab?
Yeah, that's the
Definitely
Dom,
out of
right?
my wheelhouse.
I
have no idea.
I like the way Dom, right? Not Dom. I like the way Dom really spelled that out a little bit because that's actually a good point right here. So, superior capsular reconstruction, so shoulder joint. Remember, this is for a massive rotator cuff repair. That kind of tells you everything.
Yeah.
This is from an irreparable massive
Ah.
rotator cuff
Learn something
repair.
every
So,
day.
I've been speaking at a bunch of physician-based conferences this last year. Too many, to be honest with you. No offense, we've talked about this quite a bit at some of these conferences and using this here. So I believe the technique was developed in Japan. And the funny part that I learned, I didn't realize this here, I think it was developed because it's something along the lines like they can't do reverse shoulders or something in Japan.
I think that's the story. Yeah.
There's something about that. I remember somebody talked about that in one of their presentations. Was that
Yeah,
at this
yeah,
course this
that was-
weekend too?
yeah.
Yeah. So they did that as a way instead of doing it, but realize this is the spectrum of a massive irreparable rotator cuff repair. Right, so that tells you a lot about where the status of this person's tissue quality and stuff like that. So this isn't certainly anybody that you're accelerating to really go through fast and rehab. This is like a salvage procedure, right? If you have osteoarthritis, I'm pretty sure you're probably going to get a total shoulder at this point with that type of person. And you can do things like the reverse total shoulder as well, or this type of thing. So this is new, right? They're using like a scaffold almost. It's like, you know, I think they used to use more autograft tissue like TFL and stuff like that, but I think now they have quite a bit of allograft tissue that they can use from. But they're putting that superiorly, and think about it. So what's happening is they're trying to prevent superior humeral migration, because that's what, you know, with a rotator cuff tear, over time as partial tears get worse and worse and worse, you get more and more superior migration, and it just keeps wearing down on the rotator cuff. It wears down, right? Whoa, wait. Did we just talk biomechanical and how it relates to pathology? Yeah,
No.
it does, right? So, I mean, pretty clear. If you have a partial rotator cuff tear, you have increased superior migration, and then that translates to complete tears over time. It's just degenerative in nature. So, biomechanically, what they're trying to do is put that at the top to prevent that superior humeral migration. And I think, Mike, what they say in the conference, outcomes are decent, right?
Yeah, it definitely does, and it depends. There's a couple of different surgical techniques, but it definitely limits superior migration of the humeral head by like a good amount. And I just looked at something this morning. I think it's like almost 200%. Like
Wow.
after the repair is the limitation.
That's great. So it's
Yeah.
good. And functional outcomes, they tend to do well, right? Now remember
well,
though,
yeah.
massive irreparable tears. We're talking about older population. We're not talking about people getting back to tennis, you know, and baseball like that. But functionally, I think they get back to their ADLs quite well with this procedure. So
Right.
who knows? We may start seeing it more. But to answer the question that I think he comes back to, and Len, jump in if you have anything. But like some protocols are, I wouldn't say fast. I think they're just like, you can do some cautious passive range early on, and some are just like, no passive range for 6 weeks and no strengthening times 12 weeks, which is exactly what we're finding with just the rotator cuff world anyway with the surgeons. Some are uber conservative because for this person, they're at such a different functional level that I don't think they're trying to get them back that fast. This is like a salvage procedure. You got to think of it that way. So I don't know. In therapy, I would start doing passive range. I mean, superior capsular reconstruction, I probably wouldn't go past like 90 degrees for like that first, you know, give or take month, maybe 6 weeks, depending on the tissue quality, which is clearly bad. But I probably wouldn't do that at the beginning. I wouldn't necessarily go full range. But I mean, I don't know. I probably would do something. I don't know. Len, any thoughts?
I've honestly never treated one of these. I'm definitely intrigued by it, and I've tried to do a little research on it and interacted on Twitter with some docs about it. It's, like you guys have said, it seems promising. It seems good. I think if I see extremes of doctors, then I tend to go middle of the road and to say probably early motion is probably okay, because
early limited,
maybe
we'll say
limited.
it, yeah.
But I mean, as you go into higher amounts of flexion, are you truly stressing the superior capsule?
What about external
Yeah.
rotation? Like,
Zero, yeah.
External rotation, maybe, but if you bring them out into more degrees of abduction,
yeah.
are you,
Yeah.
you know what I mean? If you're out here and doing external rotation, it might not be as stressful as if you were down by the side.
You can argue that's less stressful. That's why they're in an
Correct.
abduction pillow, because
Right.
they shouldn't do adduction.
Exactly.
Not abduction. it's
So
true.
I think it's a promising thing, and I think to answer your question, I don't necessarily know if I agree with the 4 months of no strengthening, but I think Mike said it, that there's so many other factors. There's irreparable cuffs, there's probably fatty infiltration, poor prognosis. Why the rush? But just get their motion back, get their pain under control, and get them functional eventually. You have to hopefully have time with these, although insurance is going to limit you. So
Yeah, I would agree, and I bet you they have less limitations with range of motion stuff. But I could be wrong.
Yeah,
I mean,
yeah.
certainly not a population we see a ton of here. But
No.
but again, from going to these meetings and talking to the docs, it's an option, and it seems viable.
Yeah.
It seems like one of those ones. There's why rush? What is there to rush about? So anyway, great episode. A couple of good post-op questions with some kind of different techniques. I like those. Those are good questions. Keep them coming. Head to MikeReinold.com, click on that podcast link, and you can ask us questions like that. It'd be awesome. Head to iTunes, Spotify, rate, review, and we'll see you guys on the next episode.